Hi, welcome to Practical ECG courses. My name is Obaid. I'm an emergency physician working in the UK. I enjoy teaching ECGs and I have been teaching ECGs for around 8 years now. My area of special interest is teaching concept-based approach to ECGs and how we can use these concepts in day-to-day clinical practice. I conduct an ECG series regularly, usually a session about every 1 to 2 months. Every session, I discuss one topic, starting from basic concepts and then go on to the nuances of complex ECGs. All my sessions are directed at ED doctors and is designed to help senior ED doctors develop expert level ECG interpretation skills. If you're interested and want to know more about my sessions, please visit my website www.practicalecgcourses.com. I will leave a link in the description below. So the topic for today is electrical axis, understanding axis and its relevance in ED. There are a couple of reasons for selecting this topic for today. First and foremost, I've had a lot of requests for this topic. A lot of doctors are able to calculate axis, but they do not understand what axis really is, and so they do not use it much when interpreting ECGs. Even now, I see doctors, sometimes even senior doctors, who say that axis has no relevance in ED. They could not be more wrong. It is because they do not understand it that they do not know what its relevance is. The second reason I decided to make a video of Axis and to upload it to YouTube is because understanding Axis is critical to understanding ECGs. When I do my practical ECG series, sometimes I struggle because some of the delegates attending may not be familiar with these concepts. So either I have to spend 30 minutes explaining Axis and the concepts behind it, or I need to skip the point altogether. Now, because I've uploaded this on YouTube, they can watch this prior to the session. This makes things easy for the both of us. An added advantage is that people can see what concept-based ECG teaching looks like and then decide if they want to attend my other sessions. While this talk focuses on electrical axis, I will also be introducing some related concepts which will be useful later. Starting with an overview. First, we will cover some basic concepts which you will need to know if you wish to understand axis. Then we will move on to what axis is, how it is calculated, what are the usual causes of axis deviation, and how is it relevant in the ET. Hopefully by the end of the session, you will understand what axis is and how and why we calculate it. You will no longer need mnemonics to remember the different causes of axis deviation, and you will know how it is relevant to us in the ED. Let's start off with some basic concepts first. I'm sure you're all familiar with this diagram. You know the SA node, the atria, the AV node, the bundle of His, bundle branches, and the Purkinje fibers. So what happens during a normal heartbeat? The SA node spontaneously depolarizes and produces a wave of depolarization, which results in the depolarization of both the atria and the ventricles. As you can see, the SA node is on the right side of the heart, and therefore, when the depolarization begins, the right atria gets depolarized first, followed by the depolarization of the left atria. This is referred to as sequential depolarization. In comparison, when the impulse leaves the AV node, it travels down the bundle of His. Once it travels down the bundle of His, the impulse reaches both sides, the right and the left ventricle simultaneously, and results in a synchronous or simultaneous depolarization of both ventricles. This is an important point to remember, that the atrial depolarization is sequential, whereas the ventricular depolarization occurs synchronously. Depolarization is also known by different names like electrical impulses, activation front, etc. It is also referred to as vectors. This is because each wave of depolarization has magnitude and direction and therefore can be considered as vectors. Unless otherwise specified, when I talk about vectors, I am talking about waves of depolarization. So what is the function of an ECG machine? It is to record these vectors using some leads and then inscribe it on an ECG paper as deflections. So what is the effect of direction of vector on an ECG lead? Each lead can be considered to be an eye looking for vectors. When an ECG lead sees the vector as traveling towards it, it documents it as a positive deflection on the ECG paper. When an ECG lead sees the vector as traveling away from it, it then documents a negative deflection. This is very simple but a very important concept which is critical in understanding axis. We all know that we use 12 lead ECGs. So why do we need 12 leads? You must remember that the heart is a three-dimensional organ, and so the vectors within the heart is also traveling in three-dimensional space. So to be able to pick up all the vectors, you need to have a three-dimensional perspective. So how is this achieved? This is achieved by placing 6 leads in the horizontal plane and 6 leads in the frontal plane. If you consider leads only in one plane, you cannot pick up the vectors which are moving outside of that plane. For example, V1 to V6 forms the horizontal plane. So it can pick up all the vectors traveling in the horizontal plane, for like vectors moving anteriorly, posteriorly, to the sides and all that. But it cannot pick up vectors which are traveling superiorly or inferiorly because these vectors are traveling out of plane for the horizontal plane. Now, if you look at the frontal plane, which is formed by the 6 limb leads, which are lead 1, lead 2, lead 3, AVR, AVL, and AVF. These pick up all the vectors in the frontal plane, vectors which are moving superiorly, inferiorly, and to the sides. But it cannot pick up vectors which are traveling anteriorly or posteriorly, as these vectors are out of plane for the frontal plane. But what happens when you superimpose these two planes? You then get a three-dimensional perspective, and now you can detect all the vectors in all the directions. Remember that each lead gives you a unique view of the heart, and so with 12 leads, you're getting 12 perspectives. Now, to calculate axis, you only need to be familiar with the frontal plane, but it helps to be familiar with the horizontal plane leads as well. The horizontal plane leads are straightforward, as it has 6 very visible leads placed around the chest, which is V1 to V6. But the frontal plane leads can be slightly confusing, but it is not difficult. To be able to have a good working knowledge of ECGs, and especially axis, you need to know some basic stuff, and the rest you can discard. The 6 limb leads consist of 3 augmented leads and 3 bipolar leads. Let's talk about the augmented leads first. AVR, AVL, and AVF. The name itself tells you where they are located. AVR is placed on the right upper limb, and so it looks at the heart from the right shoulder. AVL is placed on the left upper limb and looks at the heart from the left shoulder. AVF is placed on the left foot and looks at the heart from the feet. The 3 bipolar limb leads are lead 1, lead 2, and lead 3. Of all the 12 leads of an ECG, you already know the location of 9 leads. V1 to V6 is placed across the chest, and everybody knows it. AVR, AVL, and AVF, the name itself tells you where the leads are located. All you need to learn is the location of these 3 leads, that is lead 1, 2, and 3. You don't need to know how these leads end up in these locations, but you need to remember their locations with respect to the heart. Lead 1 looks at the heart from the left side, lead 2 looks from the bottom left, and lead 3 looks at the heart from the bottom right. That's all you need to remember. Lead 1 is here, lead 2 is here, and lead 3 is here. Now, if you bring together all the 6 frontal leads, this is what it looks like. AVR looking at the heart from the right shoulder, AVL looking at the heart from the left shoulder, AVF looking from the feet, lead 1 looking at the heart from the left side, lead 2 looking from the bottom left, and lead 3 looking at the heart from the bottom right. I know this looks complex, but if you look at it carefully, you will realize that this is the same thing that we have been discussing so far. This image just shows how all the 12 leads are positioned relative to the heart. The red represents the chest leads and the horizontal plane. You can see all the 6 V1 to V6 leads which is placed around the heart. The blue represents the frontal plane and the limb leads. You can see AVR, AVL, AVF, and you can also see lead 1 looking at the heart from the left side, lead 2 looking at the heart from the bottom left, and lead 3 looking at the heart from the bottom right. This is again exactly the same thing. This picture just gives you a much better three-dimensional perspective. You have AVR looking from the right shoulder, AVL looking from the left shoulder, AVF looking from the foot. In addition, you also have lead 1 looking from the left side, lead 2 looking at the heart from the bottom left, and lead 3 looking at the heart from the bottom right. The reason that I am repeating this image again and again is to imprint the location of these leads relative to the heart, especially the location of the 3 bipolar leads. That's the lead 1, lead 2, and lead 3. Now that we are done with this, building the basics, let's move on to the electrical axis. We have discussed earlier that the function of the ECG machine is to pick up vectors and to convert it into deflections. But if you think about it, at any point of time, there are millions of vectors going in different directions in the heart. I'll repeat that. At any point of time, there are millions of vectors going in different directions in the heart. Do you think the ECG machine is able to pick up each and every one of these millions of vectors? No, it can't. So what does it do? What it does is that it picks up the average of all these vectors, which is referred to as the mean vector. This mean vector represents the average direction of all the millions of vectors in the heart at any given point in time. Why is this mean vector important? Because it is the electrical axis of the heart. So what is electrical axis? It is nothing but the average direction of electrical activity in the heart. I'll repeat that once again. Electrical axis is the average direction of electrical activity in the heart. It's that simple. Now, how do you calculate axis? In this picture, you can see that the mean axis is pointing downwards and to the left. But how do you quantify this? Look at this picture of Earth. This is where I'm originally from, the southernmost tip of India. If I wanted to invite you home, how would I do it? I could tell you the directions, go right and then go left and all that. But it is a very crude and ineffective way to communicate directions. Fortunately, we do not have to do that anymore because some very intelligent astronomer devised a more efficient way to communicate directions. He drew an imaginary circle around the Earth and then drew some lines across it and called this latitude and longitude and used this to convey location. In short, he developed a system of coordinates which helped him communicate directions more effectively and accurately. Similarly, somebody drew a circle around the heart and then some lines across it and created a system of coordinates which will enable us to calculate the axis. Is this now looking familiar? This system of coordinates is referred to as hexaxial reference system. Hexaxial reference system. The name is scary, but then if you have been paying attention so far, you already know almost everything on this diagram. The name tells you what it is. It's a reference system involving 6 axes, hexa axial. You can see that here, 1, 2, 3, 4, 5, 6. Therefore, 6 axes, therefore hexaxial reference system. As I said earlier, you know almost everything in this diagram. You know that there's a heart at the center of the chest. You know that there are 6 leads in the frontal plane. There is AVR looking at the heart from the right shoulder, AVL looking at the heart from the left shoulder, AVF looking at the heart from the foot, 1 looking at the heart from the left lateral region, 2 looking at the heart from the left bottom, and 3 looking at the heart from the right bottom. So the only new thing here is the degrees, and the degrees are simple. Let me show you how. So the first axis, this one is 0. If this is 0 degrees, then this is 180 degrees. So you have 6 axes, then each axis must be separated by 30 degrees. Everything that comes in the lower hemisphere is positive, and everything in the upper hemisphere is negative. So that makes this 30 degrees, then plus 60, plus 90, plus 120, plus 150, and 180. And like I said, the axes are separated by 30 degrees, and everything that is coming in the top half is negative. So that makes this minus 30, minus 60, minus 90, minus 120, minus 150, and minus 180. That's all that there is to hexaxial reference system. Most of it is things that you already know. The only thing that was new was the degrees, but you don't even need to remember the degrees for most part, unless you want to do expert level interpretation. If so, you'll need to know the degrees, but most people don't need it. I've removed all the unwanted bits of the hexaxial reference system and kept the bare minimum that we need to know. You already know the locations of all the leads. Now, to remember the degrees, just draw a straight line. If this is 0, then this is plus 90 because it comes in the lower half. And 30 degrees on this side, you have lead 2, which is 60, and 30 degrees on this side, you have lead 3, which is 180. Similarly, 30 degrees from 1, you have minus 30, and 30 degrees from 180 you have minus 150. This is how you can derive the entire degrees without actually having to learn it by heart. I hope this is straightforward and not too complicated. If so, let's move on to axis now. Now let's talk briefly about normal and abnormal axis. Previously, it used to be believed that axes fell neatly into quadrants. At the time, it was believed that anything between 0 and plus 90 was considered normal, and anything between 0 and minus 90 was considered left axis deviation. But during research, they noticed that a lot of people, normal individuals, had axis vectors, which mean vectors, which was between 0 and minus 30. It is believed that that is because of the left ventricular thickness being more than the right ventricular thickness. Therefore, there is more depolarization and more vectors on the left side. And this pushes the vectors from the mean vector into this region between 0 and minus 30. So these days, it is believed that normal starts from minus 30. Anything from minus 30 to plus 90 is these days considered normal. Beyond minus 30 up till minus 90 is considered left axis deviation. Anything from plus 90 to plus or minus 180 is considered right axis deviation. And between minus 90 and plus minus 180 is now considered extreme axis deviation. Extreme axis deviation is also known as northwest axis deviation or no man's land. This is essentially the same thing that was discussed in the last slide. You just need to know what the degrees are for the normal and the various axis deviations. Now coming to axis calculation, there are different methods to calculate axis. There's a graphical method which is the most precise but is used mostly in research and not in clinical practice. Then there is the isoelectric method which is also very precise up to plus minus 10 degrees. We can use it in the ED but it's mostly not needed. I used to use it routinely around 8 years ago, but then these days I only use it when there is some complexity in axis calculation. The method that I use these days is a modified quadrant method. Quadrant method is the simplest method and the fastest and the most effective method. That's all that we need to know in A&E. Quadrant method is essentially looking at which quadrant the mean vector falls in. There's only one step in quadrant method. It's essentially what you're looking for is whether the QRS is predominantly positive or negative in lead 1 and AVL. The reason why you look at lead 1 and AVL is because these are at 90 degrees to each other. These two leads are at 90 degrees to each other and neatly fits into a quadrant. This works well for all quadrants, as you can see, except the left upper quadrant. When you come into the left upper quadrant, there are two possibilities. If a vector falls here, it's normal. If a vector falls here, it is left axis deviation. So when you use the modified quadrant method, for all of the rest, you need only one step. There's only one step. But when it comes to the left upper quadrant, there is one more additional step that needs to be taken to calculate the axis. Now let's move on to the next slide. Now let's apply the modified quadrant method of axis calculation in this ECG. All you're looking for is the QRS in lead 1 and AVF. Is it predominantly positive or negative? Lead 1 has a positive QRS, whereas lead AVF has a predominantly positive QRS. So, based on the quadrant method, if both are positive in lead 1 and AVF, that is normal. Now, coming to the concept behind this, you don't need the concept to actually calculate the axis. If you know the concept, it just helps, that's all. So, remember what we said earlier. When a lead sees a vector as coming towards it, it documents it as a positive deflection on the ECG. And when the lead sees the vector as going away from it, it documents a negative. So in this case, you know that 1 is predominantly positive. So what does that mean? This is 1 and this is AVF. So 1 is predominantly positive means lead 1 is seeing the vector as coming towards it. And AVF is predominantly positive means AVF also sees the vector as coming towards it. This tells you that the actual mean vector is somewhere in this quadrant between 0 and plus 90. And since this is the normal quadrant, it tells you that this patient has a normal axis deviation. This is the concept behind it. To actually calculate, all you need to know is if both are positive in 1 and AVF, that's normal. That's all. If you understand this concept, then let's move on to the next one. If not, please listen to this once again because we are going to be applying the same principles for all the ECGs that's going to follow. Now let's have a quick look at this ECG. Look at 1. It's predominantly negative. Look at the QRS in AVF. That is also predominantly negative. What does that tell us? 1 is negative. That tells us the vector is moving away from lead 1. And AVF is also negative. That tells us that the vector is again moving away from AVF. And so the actual mean vector is somewhere between these two. So this is in the quadrant for extreme axis deviation between minus 90 and plus minus 180. This is the concept behind this. So if both 1 and AVF is predominantly negative, that is extreme axis deviation. And you remember what we saw just earlier, that is if both are positive, it's normal. If both are negative, that's extreme axis deviation. So according to the modified quadrant method, look at lead 1 and lead AVF. If both are positive, that's normal axis. If both are negative, that is extreme axis deviation. In this ECG, you can see that lead 1 is predominantly negative, whereas lead AVF is predominantly positive. So from a concept point of view, what this means is that lead 1 is predominantly negative, so it means that the vector is going away from it, whereas lead AVF is predominantly positive, so it sees the vector as coming towards it. So the actual mean vector is somewhere between plus 90 and plus minus 180, which is in the right axis deviation quadrant. So if the vector is predominantly negative in 1 and predominantly positive in AVF, this is right axis deviation. A mnemonic for this is right meets. In right axis deviation, the vectors are traveling towards each other and will meet at some point. So right meets is the mnemonic for right axis deviation if you want a mnemonic. If you can remember the actual concept, well and good. So as per the modified quadrant method, if both 1 and AVF are positive, that's normal axis. If 1 and AVF are both negative, that is an extreme axis deviation. If 1 is negative and AVF is positive, then right meets comes into play, so it is right axis deviation. So far, it's all been simple and straightforward. It's because the normal and the deviations that we've discussed so far fits neatly into a quadrant. Now, the left upper quadrant, as we've discussed before, has two parts to it. A bit of it is normal, and the remaining part is left axis. So, what would we expect to see on the ECG? Lead 1 would be predominantly positive, and lead AVF would be predominantly negative. When you have this finding, it puts you in the left upper quadrant, but then you need to find out if it is on this side of minus 30 or on this side. For that, you need to go to the next step, which is to look at lead 2. If lead 2 is predominantly positive, then that's normal axis between 0 to minus 30. And if lead 2 is also predominantly negative, then that is left axis deviation with a degree between minus 30 to minus 90. It will be easier to actually interpret an ECG, and then you will understand it better. Let's have a look at this ECG. Lead 1 is predominantly positive. That tells you that the vector is moving towards lead 1, and lead AVF is predominantly negative. So it tells you that the vector is going away from AVF. Now, the question is, we know the vector is somewhere between 0 and minus 90. The question is it on this side of minus 30 or on this side? So how do we sort that out? By looking at lead 2. Now lead 2 is also predominantly negative. That tells you that the actual mean vector is in this quadrant. So in this side of minus 30, and that tells you that this is a left axis deviation. Now the concept behind why we use lead 2 is a little bit complex to explain, but does not change your practice. So just remember, if you have a left upper quadrant, if 1 and AVF are going away from each other, then look at lead 2. Now, the mnemonic that you can use for this is left leaves. You remember that there was a right meets, and when it comes to the left, it leaves. So, left leaves. 1 and AVF is going away from each other, and even 2 is also going away. So, if you draw a line here, you will see the vectors are all going away from each other. Now, let's have a look at this ECG. You can see 1 is predominantly positive and AVF is predominantly negative. So 1 is positive, the vector is going towards 1, and AVF is predominantly negative, tells you that the vector is going away from AVF. So once again, we are left in a quandary whether the vector is on this side of minus 30 or on that side of minus 30. So how do we resolve it? Look at lead 2. Lead 2 is also predominantly positive. That tells you that the vector is actually between 0 and minus 30, and that now you know that this is a normal axis. Okay, so with that, we have covered the modified quadrant method of axis calculation. To summarize once again, look at the QRS in lead 1 and AVF and see if it is predominantly positive or negative. If it is both positive, that's normal axis. If it is both negative, that is extreme axis. There's only two more possibilities. They can go towards each other or away from each other. If they're traveling towards each other, that is, if one is predominantly negative and AVF is predominantly positive, that is right axis deviation. And the mnemonic for that is right meets. Okay, and if the vectors are traveling away from each other, if one is predominantly positive and AVF is predominantly negative, then that puts you into the left upper quadrant, which is a possible left axis deviation. The mnemonic here is left leaves. Now, if you come to this situation where you have a positive in lead 1 and a negative in lead AVF, then look at the next step, that is lead 2. If that is also positive, then that's normal axis, and if lead 2 is also negative, then that is left axis deviation. I hope this is simple enough for you. The concept was just to make you understand how this thing actually works, because a lot of people don't understand it, and this is supposed to be a concept based teaching class. So I hope you understand it, but you don't need the concept to actually calculate axis. The concepts are helpful with so many other things, but not with the actual calculation of axis. So let's quickly do a couple of ECGs. Just using the modified quadrant method, no concepts, nothing else. So look at lead 1, predominantly positive, lead AVF, predominantly positive. So both are positive, makes it normal axis. In this ECG, one is predominantly negative and AVF is predominantly positive. So both are traveling towards each other. That's right meets, and therefore this is right axis deviation. In this ECG, one is predominantly positive, AVF is predominantly negative. So they are traveling away from each other. So that makes this a possible LAD. So what do? Look for lead 2. Lead 2 is also negative. So that makes this a proper LAD, a left axis deviation, where the vector is between -30 and -90. In this ECG, you can see that one is predominantly positive and AVF is predominantly negative. So the deflections are going away from each other. So that makes this a possible LAD. So what do? Look at lead 2. When you look at lead 2, that is also predominantly positive. Now you know that it is not an LAD. It is a normal axis between -0 to -30. And the last practice ECG for today. One is predominantly negative and AVF is also predominantly negative. So both are negative, makes it extreme axis deviation. Now let's look at some of the common causes of axis deviation. Once upon a time, I struggled to remember the causes of axis deviations. I used mnemonics, but that didn't help. If you also have been struggling with it, then you do not need to any longer, because you already know all the concepts that you need to understand the different causes of axis deviations. Now, what you need to remember is that axis is determined by vectors. So if you have more vectors on one side, the axis will deviate to that side. For example, if you have more muscle mass on one side, then there is more myocardial cells to depolarize, and therefore more vectors will be on that side, and therefore the axis will deviate to that side. Now, for some reason, if there's no conduction going on one side of the heart, then it doesn't have that many vectors, and all the vectors are on the opposite side, and therefore the axis deviates to the opposite side. This is commonly seen in conduction abnormalities, where one side of the heart is not getting any impulses, or can also be seen in some cases of old infarction. Infarcted tissue is dead tissue and does not conduct impulses. So all the vectors will be moving somewhere else and the axis deviates in that direction then. Now, before we move on to the commoner right and left axis deviation, let's quickly discuss extreme axis deviation, because it has only two causes which are relevant to us in the A&E. Normally, you would expect a sinus impulse to cause depolarization of the heart in this manner, and therefore the mean vector will be in this direction, which is normal. Now, if you need to have an extreme axis deviation, the vector needs to go this way. How can you have that? The commoner condition that we see in the NE is ventricular tachycardia. When you have an ectopic foci in the ventricles, especially in the apical ventricles, the wave of depolarization starts from the bottom and then goes backwards till the entire ventricle, and then the atria gets depolarized. So what happens to the mean vector? The mean vector is going in this direction, which is extreme axis deviation. So the most important cause of extreme axis deviation for us in the ED is VT. The other important cause of extreme axis deviation is when you have a right arm, left leg limb reversal. This can also cause an extreme axis deviation. It's not very common, but it can also cause extreme axis deviation. Now let's look at some causes of left and right axis deviation. Suppose you have LVH, the ventricular myocardial mass is significantly increased. What happens to the vector? it deviates to the left side. Like I said earlier, whenever there is more myocardial mass, you have more vectors on that side, and therefore you have a left axis deviation. So LVH is associated with left axis deviation. And suppose the reverse is true. Suppose you have right ventricular hypertrophy. If the right ventricular hypertrophy is so much so that it is thicker than the left ventricle, then what happens to the vector? It moves to the right axis quadrant. So you have a right axis deviation with RVH. Now, where do you normally see RVH? In which age group? That was a clue. So, in pediatrics. So, pediatrics, especially very young children, tend to have a right axis deviation, as you know, because of the increased right sided pressures due to the intrauterine blood supply and all that. Now, suppose you have a patient with a lateral wall MI, an old lateral wall MI. What happens in lateral wall MI? This part, the lateral wall gets infarcted, and then there is no vectors in this region. So what happens to all the vectors? It goes into the territory of right axis. So old lateral wall MI is a cause of right axis deviation. And what happens similarly when you have an old inferior wall MI? Inferior wall MIs are associated with right ventricular MI as well. So this area is not getting adequate conduction. And what happens to the vectors then? It goes to the left side. So old inferior wall MI is a cause of left axis deviation. Now suppose a patient has LBBB. I'm sure you all know this is the right bundle and this is the left bundle, and the left bundle has two branches. This is the anterior fascicle, left anterior fascicle, and this is the left posterior fascicle. Now let's keep things simple, get rid of all that. So essentially you have the right bundle branch and the left bundle branch. Suppose the left bundle is completely blocked. What happens then? Remember what we discussed earlier. The ventricles gets depolarized simultaneously. Both sides are supposed to get depolarized simultaneously. Now, when you have a left bundle branch block, the impulse can't go down the left bundle, and therefore the left ventricle is not getting depolarized. But at the same time, the right ventricle is able to get the impulse, and therefore the right ventricle gets depolarized first. And when it finishes depolarization, the left ventricle is still not depolarized. Therefore, it sends impulses this way from the right ventricle to the left ventricle, and the mean of all those vectors is going into the region of the left axis deviation. This is the reason why left bundle branch has a left axis deviation. Now, what would you expect in the case of a right bundle branch? The opposite, isn't it? You would expect that the right bundle branch has a right axis deviation. But it is extremely important to know that right bundle branch block does not have any axis deviation. I would like to re-emphasize that isolated right bundle branch block does not have any axis deviation. This is very important because if you have an axis deviation, then it becomes a bifascicular block. So remember that while left bundle branch block causes left axis deviation, right bundle branch block does not cause right axis deviation or left axis deviation for that matter. Now let's look at fascicular blocks. The left bundle divides into left anterior fascicle, and this is the left posterior fascicle. Now what happens, for sake of simplicity, let me just draw that here. You have the AV node, the bundle of His, then you have the right bundle branch, and then you have the left bundle branch, and then that divides into left anterior fascicle and left posterior fascicle. So just imagine this is how it is. So what happens when you have a left anterior fascicular block? If you have a block here, this is called LAHB or LAFB, left anterior fascicular block, or left anterior hemiblock. So when you have a left anterior hemiblock, the impulse can't go down this way. So what happens? The impulse goes down the posterior fascicle and then goes this way. So in short, when you have a left anterior hemiblock, the impulse goes down this side and goes all the way there. And therefore, left anterior fascicular block produces a left axis deviation. Now, what happens when you have a left posterior fascicular block? So this is left anterior fascicular block. When you have a left posterior fascicular block, the impulse can't go down that direction. So it goes to this side and then comes down that way. So what you would expect to see here is there's a block here. The impulse comes down this side and then the vector goes into the right axis side. So left posterior fascicular block produces right axis deviation. What happens when you have a paced rhythm and when the pacing electrode is placed in the right ventricle? The right side of the ventricle gets depolarized first, and then the left side of the ventricle gets depolarized. So this is similar to a left bundle branch block, because once the right side gets depolarized, it sends impulses onto the left side. So right ventricular pacing causes a left axis deviation. What happens when you have increased right-sided strain, such as in conditions like P? Again, you would expect to see a right axis deviation. So whenever you have a right-sided strain conditions like PE or even COPD, that causes a right axis deviation. In COPD, there are multiple reasons why you have a right axis deviation. One is the right-sided strain producing right atrial and right ventricular hypertrophy. In addition to that, you have a tubular mediastinum. So when you have a tubular mediastinum, what happens to the heart? The heart, instead of being in this position, becomes like this, and therefore that produces right axis deviation. There's also a bit of a clockwise rotation of the heart in COPD. It's a little bit difficult to explain. You don't need to remember that. Just remember COPD also produces right-sided pressures and therefore produces a right axis deviation. Now, what if the patient's heart is not in this side? Instead, the entire thing has changed side and you have a dextrocardia. So again, that produces right-sided dextrocardia. Yeah, and again, dextrocardia produces a right axis deviation. What if the patient has a horizontally displaced heart? Suppose the patient is pregnant or obese and or having ascites, and the heart is in this manner. It's horizontally displaced. The vector will again go into the left side, and therefore horizontally placed hearts is again a cause of left axis deviation. And what about vertically placed heart? That is the same thing what we've seen in COPD, tubular heart. So vertical displacement of the heart again produces right axis deviation. And with that, I think we have covered the concepts behind almost all the causes of all the significant axis deviations that we can expect to see in ED. This is the same thing what we have just discussed. There are 3 points that I want you to take away from this slide. The most common cause of left axis deviation is LAHB, left anterior hemiblock. LPHB, while it is a cause of right axis deviation, it is one of the rarest causes of right axis deviation. You should never diagnose left posterior hemiblock until you have ruled out all other causes of right axis deviation. And the third point I want you to take away is what I discussed earlier. Right bundle branch block is not a cause of right axis deviation or left axis deviation. Isolated right bundle branch block does not have any axis deviation. So we have finally reached the last part of today's talk, that is the clinical significance of electrical axis in the ED. Now there are many reasons why electrical axis is relevant in the ED. I have listed just 6 of the most important reasons. The most important reason why we should be familiar with axis is because it helps us identify the presence of hidden abnormalities in normal looking ECGs. If you see an axis deviation, you should be able to explain it. Second, it is a part of the mandatory criteria for the diagnosis of trifascicular blocks. Axis can help you diagnose VT and to differentiate VT from SVT with aberrancy. There are 2 ways it does this. The first is what I've just discussed a couple of slides ago. When you have a wide complex or a broad complex tachycardia with extreme axis deviation, it is highly suggestive of a VT. I think that's self-explanatory, and I won't need to explain that. The second way to distinguish VT from SVT with aberrancy is if a patient has a wide complex tachycardia during which the axis is shifted by more than 40 degrees from the baseline sinus rhythm, then that is also suggestive of VT. Now that might seem a little bit confusing, so let me explain that. Suppose you have a patient with a baseline aberrancy, such as a bundle branch block or something like that, and you know the axis at baseline. Suppose it is, in this case, maybe around 60. And then the patient has come in with a wide complex tachycardia. And when you calculate the axis in that, it is somewhere around minus 90 or something like that. So now there is more than a 40-degree shift in axis from 60 to minus 90. So that tells you that this wide complex tachycardia is a VT. It's strongly suggestive of a VT. The reason is when there is a VT, the axis completely shifts. So if there is more than a 40-degree difference in in axis from baseline. So the scenario here is you have a patient with a wide complex tachycardia. Look at the ECG, look at the axis. You have an axis. And if you have an old ECG, look at the axis there. If there's more than 40-degree difference between the two, then it is more likely than not that the wide complex tachycardia is actually a VT. I hope that's clear. Now, if you have a patient with an ST elevation in the right side at leads like AVR and V1, and the patient also has a right axis deviation, then it is extremely unlikely to be an acute STEMI. It is more likely to be either a PE or a hyperkalemia. PE and hyperkalemia are notorious for producing ST elevations in the right sided leads with the right axis deviation. Remember that acute STEMI does not normally cause right axis deviation, whereas a completed myocardial infarction, an old STEMI, can produce right axis deviation, as we have discussed in the case of old lateral wall MI and old inferior wall MI. When you have sodium channel blockade, there is a rightward shift in the terminal 40 milliseconds of the QRS, which is manifested on ECG as deep slurred S wave in leads 1 AVL and an R wave in lead AVR. So we have discussed 5 conditions, 5 life-threatening conditions, which produces axis deviation, and you need to know axis if you are going to diagnose these conditions. Now there's one more important reason why you need to know axis clearly. It is credibility. If you're going to interpret an ECG and going to make big and fantastic diagnosis and talk to somebody else, maybe a cardiologist, maybe a junior, and you do not know or you're not familiar with what axis is and how it is and how to interpret it, then there is no credibility for the rest of your ECG interpretation. So for these 6 reasons, we all must be thorough. Any doctors must be thorough with axis. I hope this was useful, And I hope it's become a little bit more clearer than it was previously. And with that, we are done with today's session. This is a very good free resource which you can use to practice axis calculation. If you go to the link, you will see this hexaxial reference system on one side and the ECG on the other side. This arrow, you can actually drag it to either side, and as you do that, the ECG will change appropriately. So in addition to this, like I said, you do have a quiz, and this arrow will show you what the degree is. So there's another way you can use this. If you're in the AD and you have a difficult ECG and you're a bit confused about the axis, you can actually go to this app, and then what you do is just change the arrow so that the frontal leads of this app is similar to what you see on the ECG, and then you will know what the axis is. To briefly recap what we have covered today, we have covered some basic concepts, including what is the effect of a vector on a lead and the lead positioning. We have also covered what is axis, what are the concepts behind it, how do you calculate axis, and what are the common causes, and what is the relevance of axis in ED. Thank you for taking the time to listen to this session. I know it was a bit longer than usual teaching sessions, but I hope this was really useful for you, and now that you have a clear understanding of cardiac axis and its relevance in the ED. If you found this useful, please like the video and consider subscribing. If you would like to know more about my concept-based ECG teaching sessions, please go through my website www.practicalecgcourses.com. I will leave a link in the description below. Have a nice day.